Hi, everyone, and welcome to the Multiple Sclerosis Foundation. I'm your host, Kimani Hendricks, Multimedia Communications Coordinator for MS Focus, and I'm joined by Dr. Ben Thrower, whose topic today is MS Doesn't Have to Be Scary. We will address all questions and comments after the presentation. Dr. Ben Thrower is the Medical Director for the Andrew C. Carlos MS Institute at the Shepherd Center. He previously served as the Medical Director for the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the Senior Medical Advisor for the Multiple Sclerosis Foundation and enjoys contributing to their quarterly magazine. Dr. Thrower, thank you for being with us today, and I turn it over to you.
Great. Thank you very much. And thank you for everyone for joining in. I hope everyone is staying safe and healthy in these somewhat challenging and strange times. So because we're coming up on Halloween, I thought it would be fun for us to sort of take on maybe a scary topic and maybe make it a little bit less scary. So we're going to cover some myths and misconceptions as they relate to multiple sclerosis and determine whether these are fact or fiction. And then we'll talk about kind of what's true and not true. We'll have some time at the end for Q&A, so get your questions ready. So the first thing that we're going to touch on is the numbers of people with multiple sclerosis. So for the longest period of time, so I've been in the MS world since 1999 and worked with people with MS for a few years prior to that even. We told people with MS that there were 400,000 individuals with MS in the United States. And that number persisted up until about 2 years ago when we finally got some updated numbers. All of us knew that there were more people than this. And we know now that there are about 1 million people in the United States. That's our best guesstimate. So we do know that MS is the leading cause of non-traumatic disability in young adults in the United States. If you look at states in the Southeast, so for instance, Georgia, and I think the numbers are pretty similar for Florida and Alabama and the Carolinas, the prevalence of MS is about 70 per 100,000 people. If you were to go to, say, Minnesota or New York State or Washington State, you'll see numbers more like 200, maybe up to 225 people per 100,000. And we'll circle back a little bit to that kind of environmental piece in just a moment. So myth number 2 with multiple sclerosis. When people are diagnosed with MS, sometimes there's concern not only for themselves, but for family members. And so some people are afraid that MS is a strongly hereditary condition. In fact, while MS does have a genetic component, it's actually a fairly weakly hereditary condition. So MS results from both genetic and environmental influences. We know now of over 200 genes that play a role in a person's developing multiple sclerosis. So what does that translate to in practical terms? So your first degree relatives, your children, parents, brothers, and sisters, if you have MS, those first degree relatives have about a 3% chance of developing multiple sclerosis. I tend to be a pretty optimistic person, and I always like to turn that around the other way and say there's a 97% chance of that person not having multiple sclerosis. Statistics are funny things, and if you read some studies, they may not sort of state this genetic risk in this fashion. They may say that a person with MS, their relatives have a 3 times higher likelihood of developing MS because your mom or dad has MS. And that may be true, but if you state it that way, it sounds scarier. And what you're really doing in that situation is you're saying, I'm increasing the odds of a very unlikely situation. The analogy that I use is if I told you that I'm going to triple your odds of winning the Powerball lottery tonight, you're still not going to win the Powerball lottery probably. I'm increasing the odds of a very unlikely situation. So the number I like to give out is the more practical one, and that's 3%. What if you have an identical twin So you have an exact genetic copy of yourself. Well, that's a little different. So if you have an exact genetic copy of yourself, that twin has about a 33% chance of developing MS. That's an interesting number because what that speaks to is the fact that 2/3 of the time, that exact genetic copy does not develop MS. So there's clearly something going on other than just genetics, and that's where we get back to this environmental piece. So you have to have the right genes and the right environmental influences coming together to develop MS. So myth number 3, and this gets a little bit to the environment. There's nothing you can do to lower your risk of getting multiple sclerosis. And this may be a conversation that we would have with children whose moms or dads have multiple sclerosis. There are some things that we can do that might lower a person's risk for getting MS. We can make sure that we're staying on top of their vitamin D levels. So we know that low vitamin D levels early in life do increase the risk of MS and possibly other autoimmune conditions as well later in life. Childhood and teenage obesity have been associated with a higher risk from developing multiple sclerosis. So we can stay on top of that. Cigarette smoking. There are a lot of bad things that go along with cigarette smoking, and we can add an increased risk of multiple sclerosis to that list. Some animal studies and limited human studies have suggested that diets that are higher in salt and saturated fats may also be a risk factor for the development of autoimmune conditions like multiple sclerosis. So we can't pick our parents, we can't control our genes, but these are some environmental things that we might have some control over that would lower the risk for developing MS. So myth number 4, multiple sclerosis occurs equally in all races. So this is not true. So we know that MS was traditionally a condition that we saw more prevalently in people of Northern European descent. We think that that cluster of genes that puts people at risk for MS originated in the British Isles thousands and thousands of years ago and spread out through the world over generations. This is changing now. We're a very mobile society. We're not a racially homogenous society. And so, for instance, in the United States, there may be an increasing prevalence of MS in people of African American descent. Here at Shepherd Center, about 45% of our individuals that we work with MS are African American. So it may be increasing in prevalence as we become a more mobile society. There are still areas of the world where you just rarely see multiple sclerosis. MS is very unusual on the continent of Africa, with a couple of exceptions. If you get to the extreme southern part of Africa, South Africa, where you get some mixture of the Dutch population, you will start seeing a little higher prevalence of MS. And in northern Africa, where you have more proximity to Europe, you start seeing more multiple sclerosis. True Native Americans, you see a very low risk for multiple sclerosis in Native Americans. Hold on 2 seconds. Come in. Sorry, I had to smack my medical assistant. Sorry about that. So the multiple sclerosis is very rare on the continent of Africa, Native Americans, and in Inuits, so which the Native Americans of northern North America. Myth number 5. People with MS overheat easily and should avoid exercise. So the first part of that is true. 70% of people with multiple sclerosis do suffer from heat sensitivity. That second part is not true, however. So transient worsening of symptoms of multiple sclerosis can occur, again, in about 70% of people with heat exposure. We call that phenomenon Uthoff's phenomenon. Dr. Uthoff was a neuro-ophthalmologist back in the late 1800s. Obviously, we didn't have MRIs. We didn't even have spinal taps, lumbar punctures in the late 1800s. So what Dr. Udhoff discovered is that if he had a person suspected of having MS and he put them in a hot tub, that he could actually make their vision dim. And we know that that applies to other symptoms as well. So if you go out in the summer and you get overheated and your feet get tingly or your vision dims or your foot drop starts getting worse, those are all versions of Udhoff's phenomenon. And that's actually a thing called nerve fiber fatigue. So the areas of damage in the central nervous system where the myelin has been stripped away from the nerve fiber, those areas will start working less well if you raise the core body temperature or if you use that naked nerve fiber again and again. So how does that relate to exercise? So if you exercise and you use those naked nerve fibers again and again, or you raise your core body temperature, you could experience some transient worsening of a symptom. It's not dangerous. You are not causing new damage in the brain or spinal cord. And once you rest and cool off, those symptoms are going to go away. So we know that regular exercise is beneficial for people with multiple sclerosis for many, many reasons. As we improve endurance, we may lessen the likelihood for you to have those heat-related symptoms because we change how much energy you're having to exert by exercising. We improve balance. We improve your cardiovascular health with exercise. One of the questions that comes up sometimes is, what is the best form of exercise for a person with MS? And I always like to say the best form of exercise is the one that you'll stick with and that you have access to. If I, for instance, suggest maybe an aquatics program, which I think are great for people with MS, but the person doesn't have access to a pool or they hate getting in their bathing suit, well, they're probably not going to stick with that. So we need to find something that's reasonable, accessible, and that the person is going to stick with. Myth number 6, pregnancy is contraindicated in women with MS. Sadly, we've seen women with MS given this misinformation, and it's altered their family planning. We know this isn't true. Pregnancy outcomes for moms and babies are not significantly different in women with multiple sclerosis. We joke sometimes that pregnancy can be one of the greatest MS treatments out there. And the reason we say that is that the MS tends to quiet during pregnancy. A lot of women feel sometimes that their MS symptoms are very calmed during pregnancy, especially second and third trimesters. So we do have to look at the fact that there is an increased relapse risk in the 6 months after the baby's born. And we have to factor that in. So we like to sort of make these, just help families make these decisions proactively in a planned fashion. Sometimes that doesn't happen and we get the oops pregnancies and we deal with that as it comes about. But there's absolutely no reason to tell a woman with MS that she cannot get pregnant. It is very doable, and in a planned fashion, the overwhelming majority of the pregnancies go about without any problems for mom or baby. Myth number 7, all MS therapies are equally effective. The only real differences are in safety profiles, and that's clearly not true. So we are now up to over 20 FDA-approved treatment options for multiple sclerosis. When you look across those different options, all of those drugs have different risks and benefits. Conveniences, I think, convenience, how the medicine is administered is kind of in the eye of the beholder. So, what might be convenient for one person, for instance, say it was a monthly IV infusion, maybe that's not so convenient for somebody else. Maybe the person who lives 3 hours away from an infusion center doesn't want to have to come in every month for an infusion. So that route of administration, I think, is going to be very individual as to what's appealing to someone. We do know that there are therapies that tend to be higher up the food chain in terms of their level of effectiveness. So when I look at the available options, I would argue that Tysabri, Ocrevus, Lemtrada are kind of at the top of that food chain in terms of their effectiveness. They also may come with higher side effect risk as well. So one of the things we really like to emphasize is that there is no one perfect therapy for everyone with MS. We need to find, based upon that individual's MS presentation, their lifestyle, maybe other health issues, what is going to be the best treatment option for that individual. Be careful when you're going on to either virtual support groups or in-person support groups. I know there's we want to exchange information with one another, but we also want to be careful that we don't sort of extrapolate one person's individual experiences over to how we're going to do. And I see that sometimes where someone will say, well, I was just diagnosed, how did you do on drug X? That's good to get that individual's experience with the drug, but you want to be careful about believing that that absolutely will be your experience as well. So myth number 8, natalizumab or Tysabri has to be discontinued after 2 years of use of the medication. And I hear this a lot. And the reason that this myth came about is that if you look at all individuals on Tysabri, regardless of what their JC virus antibody status is, we see the risk of PML going up after 2 years. But that's taking all individuals and not knowing what their JC virus antibody status is. So PML is a rare but very serious side effect of certain MS medications, including Tysabri. PML stands for progressive multifocal leukoencephalopathy. PML is caused by JC virus. JC virus is what we call a ubiquitous virus. All humans have been exposed to it in all likelihood, and most of us carry this virus. We pick it up in childhood. We probably pick it up via oral ingestion, and it tends to want to live in our kidneys, and we express it out in our urine, and then someone picks it up. So think about that kiddie pool that you went into as a child. You took a big mouthful of water to spit on your friend. Well, your buddy over here just peed in the pool. And so now you've got JC virus, and it just goes around and around. Normally, JC virus uses humans as transportation. It just uses us to get from one point to another, and it doesn't cause human illness, except when you have a compromised immune system. So we know that JC virus can mutate into a form of the virus that wants to leave your kidneys and go to the brain. The normal human immune system is not going to let that happen. The normal human immune system will keep that virus in check and not let it go anywhere where that's going to be harmful. If we compromise your immune system, we may change that balance, and we may shift you now to being in an immunocompromised state where the virus could enter the brain and cause progressive multifocal leukoencephalopathy. If we have people on, again, immunosuppressant drugs, if we have people on Tysabri who have higher levels of this JC virus, this form of the virus that wants to go to the brain, we may change that dynamic. Early on in Tysabri use, we had no way of knowing what your JC virus status was. A few years ago, an antibody test was developed that lets us tell whether the person has antibodies, meaning they have that neurotrophic form of the virus in their body. Early on, those antibodies were simply positive or negative. And now we've taken it one step further, and we have something called the antibody index. So we can actually give a numeric value and really try to risk stratify whether the person is appropriate for Tysabri in the first place or whether they should stay on Tysabri. So the myth that Tysabri can only be used for 2 years really is just that. We have individuals who've been on Tysabri for many, many years, and as long as we stay on top of their safety monitoring, we think they can continue to do so safely. Myth number 9, even though we have made great strides in MS treatment, everyone with MS will eventually get worse. And so this is clearly not true. So there is a wide variety of presentations and courses of MS out there. Some people with MS are going to follow a very mild course, even without treatment. One of the challenges that we have is how do we identify these individuals early on? I think our bias is towards wanting to get most people with MS on treatment, for fear that we don't want to make the wrong guess. We don't want to assume someone's going to follow a mild course and then have them accumulate disability that we can't reverse. So, but it is true that there are people who follow very mild courses and at age 90 may look back over their life and say, you know what, this was a little bit of a hassle, but it didn't leave me with significant disability. We also know that by starting of the more effective treatments early on, that we may be able to draw a line in the sand for many people with MS and not see their MS progress. Over the past few years, a term has evolved to sort of capture that idea. It's an acronym called NEDA, NEDA, no evidence of disease activity. And what this means is the person has no relapse, no progression of disability, and no new MRI lesions. So that concept really wasn't around, I would say decades ago, that you could stop MS in its tracks. But that really is the goal now: get people on an effective treatment by diagnosing them early, and get them on an effective treatment. So hopefully you see no progression. Myth number 10, most people with MS are being treated in comprehensive MS centers. Interestingly, probably only 40% of people with MS are actually going to a comprehensive MS center. So I think one of the advantages of going to a comprehensive MS center is you've got MS specialists, physical therapists, occupational therapists, case managers, neuropsychologists, all under one roof. If you don't have access to that, that doesn't mean that you can't get that level of care. In many communities, you may have all of those pieces of the puzzle, but they just may not be under one roof. So you want to work with your local resources, whether it's a neurologist who has a special interest in MS, your local chapter of the National MS Society, your support groups from Multiple Sclerosis Foundation. Just know your resources that would let you put all of those pieces of the puzzle together. We realize the importance of comprehensive MS care, being able to have all of these specialists, putting kind of bringing their expertise together. But there's another part of comprehensive care, and that's integrated care. So you want all of those pieces of the puzzle to communicate with each other. And that's going to vary from situation to situation. If you're in a comprehensive MS center under one roof, hopefully all of those specialists are just automatically communicating with each other. If you're not under one roof and you're seeing all of the pieces of the puzzle separately, you may have to play a more active role in helping integrate that care. There's nothing wrong with asking for a copy of a clinic note to be sent to you directly. Get copies of your MRIs on disk. Ask about what the electronic medical record system is. One of the more commonly used electronic medical records now in the United States is called Epic. If you had multiple providers all using that same electronic medical record, they should be able to see each other's records. Many electronic medical records now have the MyChart feature, so that you as a patient can go in and actually see your medical records and print out copies of those and bring them with you to the different specialties. So be an active participant in your healthcare and help make sure that your healthcare is not only comprehensive, but that it's integrated. Myth number 11, MS does not cause pain. We know that this is not true. We know that pain is a fairly common symptom in multiple sclerosis, but we also have to acknowledge that not everything that causes pain is due to your MS. Many of you may have experienced this, that once you have an MS diagnosis, sometimes the medical community is guilty of wanting to blame everything that comes up in your life on your multiple sclerosis. And that can be dangerous. We can miss other health problems. But we have to acknowledge that MS can cause pain outright. So spasticity, spasms can be painful. There's central neuropathic pain. So this is frequently burning hypersensitivity, most commonly in the extremities. Occipital neuralgia, fairly common head pain. So the occipital nerve is a nerve that you have one on each side that exits the base of the skull and supplies sensation to the back and side of your head. Sometimes this can be a source of pain. So people will have these sort of ice pick jabs of pain traveling along the greater occipital nerve. it's miserable. It's not dangerous. We can treat it, but we need to, for people to know there's nothing outright dangerous about this. Trigeminal neuralgia is probably one of the more severe pains that we can see in multiple sclerosis. So the trigeminal nerve supplies sensation to your face, and there are three branches. There's one along the jawline, one at the cheek, and one for the forehead. The most commonly affected branch for the trigeminal nerve is going to usually be along the lower jawline. Can be extremely painful. Not everyone with trigeminal neuralgia or occipital neuralgia has multiple sclerosis. These can occur outside of the MS community as well. But again, pain is not uncommon with multiple sclerosis. Myth number 12, it is vital to start steroid therapy as soon as possible if you're having a relapse. And this is not true. So what research has shown is that steroids speed the recovery from a relapse, but they typically don't change the ultimate outcome. So while you may want to treat a relapse with steroids, for instance, if it was optic neuritis, you wake up with visual loss, or if you had a new lesion in the spinal cord, you wake up one day and you're having new numbness or tingling in the arms or legs or difficulty walking. We probably want to treat those to improve your function right now. But if we didn't treat those relapses with steroids, you would still get better to the same degree. It's just going to take you longer to get there. So steroids may be contraindicated in some people. You may have hypertension or diabetes that make steroids just unappealing. You may have had severe side effects with steroids in the past, mood changes or weight gain or fluid retention that make steroids unappealing. And again, we need to reassure people who can't receive steroids that it is okay to just wait things out. Even if we decide not to treat a relapse, we still want to know about relapses so that we can document those. Though the presence or absence of relapses is going to factor into that long-term decision about how effective your therapy is. And so again, if we're shooting for NEDA, no evidence of disease activity, and part of NEDA is no relapses, even if it's a minor relapse, we still want to know about it and document it so that we can determine whether you're sort of getting an A+ on your MS exam and getting everything that you can get out of treatment. If you can't get steroids, or maybe you failed steroids for a relapse, there are a handful of potential alternatives to steroids out there. IV immune globulin, plasma exchange, ACTH. These are all things that we could use potentially as alternatives to steroids if people have a contraindication or they've not responded to those. And I think with that, we're going to turn it over to you folks for questions. So this is, now this truly is scary. This is our annual Halloween party at Shepherd Center. So we have a tradition of doing an open house pre-COVID, where we would invite in different teams from pharmaceutical companies, the Multiple Sclerosis Foundation, National MS Society, MSAA, to decorate the exam rooms and then have patients and family members come in and just have a great day. So this year, unfortunately, we were not going to be able to do that. We're having a much smaller event to keep social distancing, but hopefully we'll be back to more normal activities next October and be able to have some more typical fun. And with that, I will throw it open to the listeners, and we'll see what thoughts or questions people have.
Thank you, Dr. Thrower. To our listeners, there are two ways to ask questions. You can either type them into the chat box, or you can select the raise hand feature to speak with Dr. Thrower directly. If you're on a mobile device, you can click the screen to pull up the menu and select more, which is the icon with 3 dots. I'll unmute you and an alert will appear on your screen asking if you'd like to be unmuted. And for those of you on computers, the raise hand feature is in the participants window. And while we wait for everyone to find those features, I actually have a comment. I don't know if it's a myth, and if it's not, then you can send me a virtual slap or something. Um, but I know a couple people that have MS, and they told me that before their diagnosis, for some reason, they thought the diagnosis process would be easier, or that they would know what was wrong with them sooner. Because one of my friends from high school's mother, who I was really close to at the time, was hospitalized for what they were telling her was series of strokes, when really later she found out she had relapsing remitting MS. So is that, although you didn't mention it, would that kind of be considered a myth or no?
No, unfortunately, I don't think that one's a myth. So the average length of time, and I haven't seen these numbers updated recently, but for quite a while, the average length of time between symptom onset and the diagnosis of MS was between 3 and 4 years, and that is not acceptable. So we know that the sooner we can get people on treatment, the better they do with their multiple sclerosis. But to start treatment, obviously we need a diagnosis. So there's a balance between wanting to get people diagnosed quickly, but also wanting to get people diagnosed accurately. In some people, the diagnosis is very quick. It's just so classic right up front. Um, I'm going to see a 17-year-old young man tomorrow whose presentation was just so classic that he was diagnosed very, very quickly, within weeks of the onset of his symptoms. And then we do hear those situations where it drags on for years. Part of the challenge is that some of the symptoms of MS can be so nonspecific. So the most common symptom we see in multiple sclerosis is fatigue. So if you go to your family doctor and you complain of fatigue with no other neurological symptoms, there's so many things that they're going to consider in that differential diagnosis, from metabolic problems to sleep issues, that MS may come further down the list. If any of you used to watch the medical show House, you would know you'd have these medical mysteries where that they were going to try to sort this out, and very frequently multiple sclerosis was one of the things on that differential diagnosis list. So yeah, that one unfortunately is not a myth for many people. It can be a slow process to eventually end up with that MS diagnosis.
We have a question from Sarah Page Maxwell. I'm going to lower your hand and unmute you, and whenever you're ready, you can speak with Dr. Thrower.
Thank you. Hi, Dr. Thrower.
Hey
Nice to
Sarah, how you doing?
Good, good. How are you?
Good.
Um, so I am curious about Kesimpta, the new drug that came out recently, the monthly version of, I think it's pretty similar to Ocrevus. I'm just curious if there's any data on how people are responding to it now that it's out in the public.
Yeah, so Kesimpta or ofatumumab is brand spanking new, and so we don't have a lot of real world experience with it yet. I think what we're seeing from the studies and based upon its mechanism of action, I would predict it's going to be as effective as Ocrevus. Um, I'd be surprised if it wasn't in the really close ballpark. I think that this is going to be one where, when you think about Ocrevus versus Kesimpta, it's going to come down to not so much differences in effectiveness, but probably convenience issues. So Ocrevus, as you know, twice a year IV treatment, versus Kesimpta once a month subcutaneous at home, shipped in a pre-filled syringe. I think from our end, from the medical community end, I'm a little bit nervous about giving up some of our control. So one of the things I like about Ocrevus is I know when you got your infusion, I know when you got your labs drawn because we did them. With Kesimpta, I do worry a little bit about people missing a dose or being late on a dose, or maybe missing an appointment and not getting safety labs drawn. So this class of drugs, the anti-CD20 monoclonal antibodies, Rituxan, ocrelizumab, ofatumumab, have had a good safety record. But I think part of what makes the IV therapy safe is we've been on top of the safety monitoring. I think the Kesimpta, the ofatumumab, can be a great drug. I think we're just going to need to make sure we have some safety nets in place to make sure we're not missing doses or missing labs.
Yeah, yeah, that makes sense.
Yeah.
If it's okay, I have one other quick question. So in relation to COVID-19, I was told recently or heard from my neurologist that they were starting to do biopsies on COVID patients that had passed away's brains, and that they're finding COVID-19 in the brain. And she also mentioned, not directly related, but same conversation, that some people are showing long-term neurological symptoms and damage. And so I was just curious if, like, your opinion, any information on that. Her point was not to inspire fear, but just to show her main concern was that, you know, she wanted people to keep staying safe, because you don't want to pile potential neurological symptoms on top of someone who already has a neurological disease.
Yeah. And so I think, you know, COVID-19 is a really interesting virus. And I think we're learning more every day about the pathophysiology of what it does in humans. And to me, one of the fascinating things about COVID is all of the different things that it can do, you know, not only in the central nervous system, but, you know, from a cardiovascular standpoint, from a pulmonary standpoint, and why it behaves so differently in one individual versus the next. You know, the next. Why do we see some individuals who are completely asymptomatic? Why do we see some individuals who are just devastated by the virus? Clearly, I think it has effects in the central nervous system, and I think that could be a whole discussion in of itself. Are those effects the direct result of infection in the brain, or is it an autoimmune response? We know that there's also this hypercoagulable state that we can see, where you see strokes that are occurring in some people with COVID. So there clearly is a brain effect in some people with COVID. The good news is that it does not appear, from everything we're seeing, that the average person with MS is behaving differently with COVID than other people who get it. Yeah. So there is this large registry in the US. There are registries in other countries where they're looking at how people with MS are doing with COVID. And in general, they seem to be behaving about the same, which is great news. So in general, we don't think people with MS are at higher risk for getting COVID, and we don't think they're following a different course. The one caveat in there would be patients on the B cell therapies. So Ocrevus, Rituxan, and I would expect that this is going to apply with Kesimpta, ofatumumab, but there's just not enough experience in the real world. In the European data set, specifically Italy, people on Ocrevus and Rituxan did have a higher likelihood of being hospitalized if they got COVID. We have not seen that here at our center, and we take care of a lot of folks with MS on a lot of different therapies, including a lot of Ocrevus, and we've not seen our Ocrevus folks behaving any differently. And this is pure speculation on my part, but I wonder if what they could be seeing in Europe are people who are mildly immunocompromised getting COVID, having more serious outcomes. So I think and this gets back to the importance of safety monitoring. Mm-hmm. Safety monitoring with these drugs was important pre-COVID. It's probably even more important now. We know that a small subset of individuals on these B cell therapies can actually drop their T cell counts. That's not what we want to do. We want Ocrevus and Rituxan and ofatumumab to work on the B cells, not on the T cells. So the other thing that we can see with these drugs is that occasionally antibody levels, IgG levels, can drop a little bit. So it's important that we check all of those things. So part of lab monitoring with Ocrevus is to look at we want to make sure it's dropping the B cells it should, leaving the T cells alone, keeping your antibody levels up. If you are in a setting where those things are not being checked, you could have a person on one of these therapies who is mildly immunocompromised, and you wouldn't know it unless something bad happened. So again, that's one of the important things that we're doing. So we're looking at the CD19, which is the B cell marker, the T cell marker, CD4, CD8, and then also looking at IgG levels in individuals on these therapies.
Okay. Thank you.
Yeah. Good to see you.
We have a question in the chat from Karen. She wants to know if there is any particular age when you stop using Ocrevus. She asks, is it after 60 or before?
Yeah, so that's a great question. So, and I would even expand that out to all therapies, not just Ocrevus. So, is there a point at which a person, with MS does not need to be under treatment? And there probably is. The problem is we're not smart enough yet to know that when that is. And so there is this concept of immune senescence. The human immune system has hit a point where it's quieted down enough that it's not going to generate big, angry, inflammatory events to cause relapses or new lesions in a person with MS. So all of our immune systems calm down as we get older. There's a good and a bad to that. If you have an autoimmune disease, that's probably a good thing, that maybe you get to a point where your autoimmune disease is not going to be as active. The downside to immune senescence is, for all of us, is, as our immune systems maybe quiet down too much, you're more at risk for infections. So a pneumonia, for instance, that might make a 40-year-old person a little bit sick could be fatal in a 90-year-old person because their immune system is in a different place. What do we do in the real world? We don't have a blood test yet or any test that lets us know when a person with MS can safely come off their treatment. So it's a very personalized discussion. If a 65-year-old person has had stable MS for year after year after year, MRI's not changed, we start having those discussions. Could we potentially back off of your therapy? Other parts that go into that is, what's the convenience of the drug? What is there a financial hardship with the drug? Are there side effects that the person's seen? And we have, I can show you 70-year-olds who say, yes, get me off of this. Let's see how I do without it. And others say, I don't even want to take that chance. Just let me just keep running with my medication. The other thing that we want to do is, when we start thinking about coming off of therapy, is I like to make sure we've checked vitamin D levels. We really need to do that in everyone with MS. So when we're taking someone off of a drug like Ocrevus or in really any of the medicines, a lot of times we're still keeping them on their vitamin D. So, and vitamin D does offer some protection with MS. So in some of these folks, we may be taking them off of a big gun prescription drug, but we may still be keeping them on something protective in the form of vitamin D.
All right, Maya, you've had your hand up for a while. So let me lower you and I'll unmute you.
Hi, Dr. Thrower. How are you?
Good. How are you doing?
Good. So I guess it's a two-part question. So I'm in the process right now of getting diagnosed with MS. And how common would you say, or how many situations would you say you've seen movement disorders turn into potentially multiple sclerosis? So like, for example, in my situation, 6 years ago, I got diagnosed with paroxysmal dyskinesia. Spinal tap showed, crystal clear, no lesions on my spinal cord, one little lesion on my brain, but not significant enough for them to think that it was MS. To fast forward to present day, multiple lesions on my spinal cord, multiple lesions on my brain, and things of that nature. So is it common that you see like diagnoses of movement disorders turn into multiple sclerosis, or spinal taps not showing MS? I don't know.
I would consider those things to be really two separate events. I mean, that's a very unusual situation. So typically movement disorders are not autoimmune in nature. So, you think about older individuals with Parkinson's disease, a younger individual with a paroxysmal dyskinesia. The most common probably movement disorder out there is benign essential tremor. all of those things tend to have no autoimmune component. So, unless you could say that initial presentation of paroxysmal dyskinesia was actually an unusual MS symptom, which I don't think would be the case. I think these are probably two unrelated events. I mean, it does happen. It's unusual. I have individuals who have MS and then later in life develop Parkinson's disease. And again, it's just bad luck. We've never seen anything that I'm aware of in the genetics or environmental exposures that would suggest that there's a common pathway between those.
So sorry to kind of just expand on it, when you talk about like muscle spasticity and pain with that, because that's for me, that was like a primary symptom of mine with the paroxysmal dyskinesia, was intense like muscle spasticity where like 60 times a day, but that was my only symptom. So it just, like you're saying, you think it's uncorrelated, but that's why I'm trying to do research on my own to see if these two things are correlated. But when people with MS talk about muscle can't say the word.
It's a tough one.
How intense is that usually for people? Is it just muscle tremors or?
So spasticity and spasms. So when we say spasticity, we mean a chronic state of increased muscle tone. And the way that typically looks is it would be extensor tone in the legs and flexor tone in the arms. And then spasms would be the wave of increased muscle tone. So a wave of increased tone in the arms is going to cause tightness, or flexion. In the legs is going to cause extension.
Right.
Most people that have spasticity and spasms in MS have weakness to go along with it. And frequently the weakness is going to precede the spasticity. That's kind of the natural evolution of spasticity and spasms in the central nervous system, is that you have a new MS lesion, there's going to be some weakness first, and then as that lesion is there over months or years, then the spasticity and spasms come on afterwards. Dyskinesias, or unusual movements, can cause increased muscle tone as well, but technically it's different from a spasm. It can be just as uncomfortable. So the question would be, do you really have the dyskinesias, and that's the cause of the increased muscle activity, and that's causing pain, or were they true spasms? It would be unusual to have what you're describing without having maybe had some preceding weakness, and to have that degree of spasticity and spasms and only have one non-specific spot on MRI would be unusual also. And it's hard, again, and I don't want to, this is just my opinion, but listening to the way you're describing it, it sounds like it would have been a true case of dyskinesias, and now MS has developed. Bad luck, two separate neurological conditions, rather than it was really MS all along, that kind of maybe mimicked a dyskinesia.
Makes sense. Thank you.
Yeah.
Sarah has another question. She asks, do you have a recommendation of a good brand of vitamin D to take, one that's bioavailable and available in high dosage, for instance, 50,000 IU?
Yeah, the vitamin D3 50,000 unit that we typically have, I've only seen one brand out there. There may be another, and I cannot remember the company, but if you go on Amazon and you look up vitamin D3 50,000 unit, it was a company out of North Carolina, and I'm blocking on their name, but it's the only one that I have ever seen. It's the one we carry here in our pharmacy. It's the one that they carry on Amazon. I've not seen any studies of the bioavailability, but I know it gets the 25 hydroxy vitamin D levels up. To me, that's the proof of the pudding. If you are coming in with low vitamin D levels as measured by 25 hydroxy vitamin D, and I can get them up into a desired range, 50 to 70, that shows it's bioavailable, that it's doing what it should be doing. just for anyone listening on the vitamin D, you don't want to do this blindly. You don't want to just go on Amazon and buy 50,000 units of vitamin D and start taking this without knowing what your vitamin D levels are to start. So any of your fat soluble vitamins, A, D, E, and K, can be toxic if you get too much. So specifically with vitamin D, if you have vitamin D levels that are too high for too long, you get the risk of ectopic calcification. You start depositing calcium in places you don't want to deposit it, like the kidneys, get kidney stones, like the coronary arteries, and you can actually have an increased risk of cardiovascular disease. So there's a sweet spot with vitamin D where you get this therapeutic benefit, but you don't want to do it blindly.
Got another question from Maya. She asks, how common is vertigo or dizziness in MS, and are there any common therapies to alleviate the symptom?
Yeah, so vertigo is pretty common with multiple sclerosis, and we always have to do a little bit of sort of semantic detective work and make sure that what I perceive the person to be saying is what they're really describing. Dizzy is a very nondescript term. And so some people will use, if they're having orthostatic hypotension, their blood pressure is low, they'll say, I feel dizzy, when what they really are describing is a sensation like they're about to pass out. So true vertigo is this sense of movement that comes on, the room is spinning or I'm moving, sometimes brought on by changes in position. So the good news with true vertigo is there's very limited human anatomy that can generate vertigo. You're really talking, 3 locations. It's either central, it's in the brainstem itself, it's the nerve from the brainstem to the inner ear, or it's the inner ear. So all true vertigo is going to typically originate in one of those locations. MS can cause vertigo. When we usually think about treating vertigo, I'm not thrilled with our medications that we have. We have Antivert or Meclizine, and then we have transdermal scopolamine patches. They can be okay. If someone is miserable with a bad attack of vertigo, we can use the class of drugs, benzodiazepines. These are your Valium, Ativan type drugs, just to kind of get the person more comfortable to get past that. I think we see better treatment results with vestibular exercises. So these are exercises that are done to try to help the body accommodate and actually push past the vertigo. There's some really simple forms called Brandt's exercises that we can give people instructions in how to do at home. More severe cases of vertigo, we may have to get a specialized physical therapist involved to work with vestibular exercises. And then there are neurologists and ENT doctors who specialize in vertigo who have other things that they can use. We have one of our neurologists down the street at our wellness and rehab center is a neurologist who specializes in treating vertigo. And he has a whole team that he uses down there for really severe cases of vertigo.
I think that's all the questions we got to everybody, which is good. So that's all the time we have for now, you guys. If you missed any part of this conference, it will be available on demand on our MS Focus SoundCloud page, msfocusradio.org, and the Multiple Sclerosis Foundation YouTube channel. So be sure to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next conference will be next Tuesday, November 3rd at 3 p.m. Eastern Time, with Dr. Alan Bowling, who will cover integrative medicine and MS. And we thank all attendees for participating, and especially you, Dr. Thrower. It's always good to have you, and it was nice to meet you formally. And we hope that you guys stay safe and well. And thank you for sharing this information with us today.
Thank you. Thank you for attending, everyone. Everybody stay safe.